All righty, welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to start by thanking our sponsors, AstraZeneca, Amgen, and Novartis, for supporting the webinars. And today's webinar is Childhood Onset of Takayasu Arteritis with Dr. Samuel Gagné. After we finish the webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who's registered today will receive an email with a link to it just as soon as it's available. That all the housekeeping is done, I would like to introduce our guest for today. Dr. Samuel Gagné is a pediatric rheumatologist at UPMC Children's Hospital of Pittsburgh and is an assistant professor of pediatrics at the University of Pittsburgh School of Medicine. He earned his Bachelor of Science degree in Biology and Neuroscience from Brandeis University and his Doctor of Medicine degree from Eastern Virginia Medical School. He completed a residency in social pediatrics at Children's Hospital at Montefiore in Bronx, New York, and a fellowship in pediatric rheumatology at Nationwide Children's Hospital in Columbus, Ohio. And while in fellowship, Dr. Gagné also completed a master's in public health with a focus on biomedical informatics from the Ohio State University. Dr. Gagné joined the Children's Hospital of Pittsburgh in 2023, and he has a clinical and research interest in chronic childhood vasculitis and is a member of the Childhood Arthritis and Rheumatology Research Alliance Chronic Childhood Vasculitis Work Group, as well as a member of the International Pediatric Vasculitis Initiative. So welcome, Dr. Gagné. I'm so happy to have you with us today.
Thank you. I'm happy to be here.
And before we get started, would you mind letting us know if you have any disclosures?
No, I have none.
Okay, and for everybody who's participating today, we have a question for you. We would like you to type into the chat box just so that Dr. Gagné has an idea. Are you someone living with Takayasu's arteritis, or are you a caregiver for a child or other family with Takayasu's, or any other information? If you would just put that in the chat, that'll give him a little bit of an idea, and he's gonna share his screen and we'll look at the chat box and see what you've had to say. Well, I'm not seeing any answers in there.
Okay.
That's okay. They might pop up when you get going. They might pop up.
Yeah. Should I go ahead and get started then?
Sure. I did see both parent and child for one person, and someone else says patient with childhood onset.
Yep, I know Katrina. Hi, okay. Katrina. Okay, so I guess I will go ahead and get started. So thank you so much, Kathy, for the introduction. Again, I'm Dr. Samuel Gagné. I'm up in Pittsburgh, Pennsylvania. And so this talk is called Evening Out the Score, Disease Assessment in Pediatric Onset Takayasu Arteritis. So I always think it's kind of interesting to look at medical history for a quick moment, especially when we have these diseases that have random people's names, the eponyms. And so for Takayasu, it's interesting. Unsurprisingly, the physician who came up with the condition is Dr. Takayasu, Mikito Takayasu. He was from Kanazawa University in Ishikawa, Japan. And he actually first described this condition in 1908. He was an ophthalmologist, and he was describing some just interesting eye findings, which coincidentally we don't actually see that often. But he was describing it at the Japanese ophthalmology meeting, where a couple other people noticed the same thing, and they decided to come up with this disease. 1908 is a long time ago, and just to kind of put that in perspective beyond just the immediate number, steroids, as we know them, were invented probably somewhere in the 50s. So this was, steroids, as I'll mention a little bit later, being one of the mainstays of treatment now, was well before any substantial treatment. So this is a condition that's been around for quite a long time. All right, so what is Takayasu arteritis? Just a bit of an introduction on the condition itself. So it's an autoimmune inflammation of large blood vessels. And so what do we mean by large blood vessels? And I don't know if anybody's seen this picture. I can tell you that every single pediatric rheumatologist ever has seen this picture. This is from what was called the North Carolina Chapel Hill Consensus Conference back in the 2012, where we kind of established as, rheumatologists as a whole, how to differentiate the different kinds of vasculitides and the, diseases where we have the blood vessel inflammation. And we basically decided to do it on the size of the blood vessels involved. And so Takayasu is a disease along with giant cell arteritis that affects mostly large blood vessels. So we're talking about aorta, so the large blood vessel that comes off of the heart, and then most of the immediate branching vessels thereof. So the blood vessels that go up into the neck, the vessels that supply a lot of our organs in our stomach, etc. It's a very, very rare disease. So, incidence is kind of always a little bit of a challenge to truly get a hold of, but roughly, it affects about 1 person per million people per year, which is not a lot. The rates are a bit higher in Asia, so Japan, China, India, but it does occur all over the world. It's most often going to be in young women. It's about 6 to 10 times more common in women than it is in men. And usually the typical patient is going to present sometime in their early 20s, although of course this is a talk on childhood onset disease, so we certainly see it in other ages. So how does it present? So constitutional symptoms, what we use that term to describe fevers, fatigue, night sweats, malaise, just kind of the feels like a bad cold, which we do see in a lot of our autoimmune diseases, including vasculitis. For Takayasu, one of the more unique aspects is that we have blood pressure issues. Often that the blood pressure is high, but also we can see a difference between the right arm and left arm, or a difference between the upper extremities and the lower extremities. One of the other hallmarks is elevated markers of inflammation, so the erythrocyte sedimentation rate, or ESR, or the C-reactive protein, CRP. Those are also pretty not super specific, and I'll talk about that in a bit. But they're usually pretty high in Takayasu arteritis. These 3 categories of symptoms are what is the typical triad for Takayasu. So a large percentage of patients present with at least these 3 symptoms or categories of symptoms, although again, it's very varied. Pain is a very, very common symptom of Takayasu arteritis, and it can be arthritis, where you have true swelling of the joints. It can be arthralgia, where you have the joint pain without the actual swelling. You can have muscle aches, body aches, and then sometimes people with Takayasu get what's called claudication, which is when they have usually lower extremity, like feet pain, leg pain with activity. And that's related to that more than the arthritis and other kind of joint issues is related to the blood vessels that are involved. You can also have issues in your head. People can get headaches, but they can also get things such as dizziness, fainting, their vision changes, and some, in rare cases, stroke. Unsurprisingly, since it affects one of the large vessels that comes off of the heart, you can have issues with your heart. So you can have chest pain, neck pain sometimes if it affects the blood vessels that go up into your neck, and then sometimes even heart attacks. And then belly pain is actually a not uncommon symptom as well. Usually it's just severe belly pain, but there can be some diarrhea or other kind of things associated with it. So how do we diagnose Takayasu just in general? It's tough. It's a challenging disease to diagnose. It requires a pretty high clinical suspicion. So basically, it requires us as rheumatologists to think about it and pursue the testing and kind of all those things that would be required to diagnose it. But we have to really think that it might be there because it's not otherwise very overt. The other aspect of the clinical suspicion is we have to do those aspects of the physical exam that we may not do in every single person. We're probably not checking blood pressures on all the limbs in every single patient. We're not checking pulses in multiple different places in all of our patients. And so these are aspects to the exam that we might do if we have that concern. It's also tough because the labs aren't specific. I mentioned the ESR and the CRP. Those are very frequently, although not always, elevated, but they're elevated in a lot of things. Any of the other types of vasculitis can have elevated ESR and CRP, other autoimmune diseases, the common cold, any kind of infection. Honestly, I tell some of my folks, because I see lots of patients for these types of lab abnormalities, you could have sneezed wrong. So while it's something that is important in the diagnosis of this disease, it's not something that is very specific to it. And so it can make it tough. And then it's tough because we really need imaging. We can have that clinical suspicion, we can do our exam, and in rare cases, we have the picture, but generally speaking, we actually need pictures. And so sometimes that involves CAT scans, so CTA, CT angiography to look at the blood vessels, but probably most often we're doing MRI angiographies or MRAs or PET scans. And we're looking for inflammation within the blood vessel walls, which is usually remarked as enhancement. We're also looking for aneurysms or dilations. We're looking for narrowing of vessels. But one of the other things that can make even imaging diagnosis difficult is the disease can sometimes burn out. And so we have this period within patients with Takayasu where you have significant disease activity and it kind of just goes away, but you're still left with some of the vascular issues because of that prior inflammation. And if there are any other rheumatologists on there, this is a semantic argument waiting to happen. But there are classification criteria that we can use. Really what it is to differentiate Takayasu from other types of vasculitis and really large vessel vasculitis, because there are other causes of, say, inflammation in the aorta than just Takayasu. In times past, we used to have kind of distinct clinical symptoms that we would use. But nowadays, especially within the vasculitis world, we're moving towards this point system that I think is a lot harder to do on the fly, but probably a lot more accurate in correctly classifying our patients. And so how do we treat it? This is actually straight pulled from one of the ACR, the American College of Rheumatology's treatment guidelines, and it's pretty simple. Okay, so anyway, treatment. So the treatment for Takayasu, there's not a lot, which is kind of evident by this tiny little graphic. But basically, as I mentioned before, steroids, so prednisolone, methylprednisolone, dexamethasone, any of the ones that you probably have come into contact with are a hallmark of the treatment. But what we found way back when is that you can't treat this with steroids alone. If you treat it with steroids and you wean off of the steroids, there's a high risk that the disease comes back. And so we use steroid-sparing agents. And listed here are methotrexate, azathioprine, TNF inhibitors, so that includes things like adalimumab, or the brand is Humira, golimumab, the brand is Simponi, infliximab, the brand is, there's a ton of them nowadays, but the classic one is Remicade. As well as, if you kind of look on the bottom, that TCZ is tocilizumab, which is Actemra. In times past, they would use cyclophosphamide, which is a stronger immune suppressive medication they also kind of use in the chemo world, but we've really moved away from that. And honestly, there's a lot of movement towards more of the biologic medication, which is the TNF inhibitors and the tocilizumab. So what about kids? So in kids, we are dealing with a much, much, much more rare disease. And so just kind of going back to earlier when they said the roughest incidence in adults is about 1 per million per year. In kids, somewhere between 5 and 50 times more rare. It's tough to make the estimates because it's so rare, but the range is from 0.04 to 0.5 per million kids per year. And if you roughly math that out, which I decided to do earlier, that means that there's, give or take, 200 kids diagnosed with this per year over the entire world. So we are, as I said, talking about a very rare disease. It's interesting in kids. It's still mostly girls that are affected by this, but it's not as skewed in that way. Instead of like 6 to 10 to 1 of a ratio, it's only about 3 to 1 girls to boys. And then the average age of onset is also unsurprisingly lower for childhood onset disease. The numbers they'll give you is 12, but really it ranges wildly. I have seen anywhere from diagnosed at age 1 to age 18 and everything in between. At our center, we have 2 patients that are actively being treated for Takayasu. One was diagnosed at age 8, one was diagnosed at age 14. So it really varies. The presentation is pretty similar. There's not a huge amount of differences between, so far as we know, between childhood onset disease and adult onset disease. There's a couple differences that some of the studies have shown. Kids tend to present a little bit more with the belly pain, and they're more likely to have high blood pressure. And both of those are actually related to the fact that kids are more likely to present or to have inflammation in the aorta and branches of it that are below their diaphragm. So the branches of the aorta that supply the stomach, the branches of the aorta that supply the kidney, etc. And so that's why they are more likely to have those symptoms. And and the continuation of that is they're less likely to have heart issues, which is great. And they're also less likely to have the limb pain, arthritis, arthralgias, those kind of things. They can still get claudication, but it's a little bit less often than adults. Unfortunately, they do tend to be more severe at presentation, and it can be life-threatening. But the positive end of that is that they tend to present much quicker. In adults, it can be usually it's over a year before from first symptom to diagnosis. In kids, it's less than a year, and it's still a lot of time in the grand scheme of things, but thankfully not as much. So challenges. So obviously, kids childhood onset disease is tough. It's just the diagnosis of adult disease is difficult, but it kind of goes to another degree in kids. One is that our ability to have a standardized diagnosis is a little bit more limited. What I showed before from the American College of Rheumatology, that came out, I think, 3 years ago. Since I'm on my laptop, I lost my notes. Um, um, and it really was only tested in adults. I think there's probably work, and that's one of the things I would actually love to do with this, the research that I'll talk about in a little bit, is to look at those classification criteria in kids. But generally speaking, we can assume, but we don't know if that is appropriate for kids. There is a set of classification criteria that has been made for childhood onset disease. It was put out by the European societies, so EULAR, which is the European League Against Rheumatism. It's my absolute favorite, like, doctors association name. It sounds like they should all be wearing capes. Anyway, that's EULAR. And PRESS, which is the Pediatric Rheumatology European Society. And they came out with a criteria back in 2008 called the CARRA criteria. The struggle with that is, while if you hit all 5, it's like 100% you have the disease. If you don't hit all 5, it doesn't mean you don't. And so most people don't follow textbooks. Most people don't read the textbooks when they come into our offices. And so, like, it's good for being sure, but it's not great for capturing the broad presentations that can really happen in this condition. Another challenge is that imaging, which is, as I mentioned, a hallmark of diagnosis and monitoring disease, can be tough. Especially for the young kids. For, like, MRIs require you to sit in a tube for a prolonged amount of time and not move. Anybody who's had young kids knows that can be tough. I mean, anybody who's sat in an MRI knows that can be tough. And so sometimes we have to sedate young kids so they don't move, which always comes with risk. We also, in pediatrics, try really hard to limit radiation exposure, especially as somebody's still growing. And so CAT scans, which have a little bit, it's not too bad. A CAT scan is like going in an airplane, basically. But PET scans, which work a lot better, they have a lot more radiation. And so, we're sometimes caught a little bit between a rock and a hard place in terms of how to diagnose and then monitor these kids. And in the same way, it's difficult to really quantify disease activity. How do we say this, your disease is more active than it was before? How do we track, amongst the same patient or between patients? This is really important. It's important for research purposes because when you're trying a drug in a patient, most drug companies want you to be able to say in some objective way that things are better. But it's also helpful for us day to day to be able to look and say, yeah, you have improved or, there's something that needs to be changed. Currently for Takayasu, there's two things that we can use in kids. So one is called the Pediatric Vasculitis Activity Score, or PVAS. This is an adaptation, if any adults have ever seen these before, of the BVAS, the Birmingham Vasculitis Activity Score, which is used in adults. Basically, it's a lot of the same things with some adaptations specifically for kids. It was validated, so basically they tested it and found that it worked in a large population of vasculitis patients, childhood vasculitis patients, but only a handful of those patients were Takayasu patients. And you can see there's this very small block that encompasses some of the vascular issues that we might see in Takayasu. And it doesn't, even though this is the scoring for this is very complicated, it doesn't really account for differences in location or quantity of location, right? I think we can kind of assume that somebody who just has disease in one spot maybe has a little bit less disease than somebody who has disease in 10 different spots, but it doesn't give us that ability to do so. Contrast that with what's called the ITAS, the Indian Takayasu Arteritis score. This is, unsurprisingly, it's the ITAS 2010. It's from 2010. It was created from a large population of Indian adults with Takayasu. And as you can see down here, it does take into a little bit of account, more of account, different places. And it's a sum score, so you sum up all of the things that are abnormal. Some things have different values, but it's not terribly relevant. But this has only been thoroughly evaluated in adults, and there are a couple things that probably don't make a lot of sense for kids. When we look at blood pressure in kids, we don't use specific number cutoffs for a lot of them because they're different sizes and different ages, and so we use percentiles based on their age, their gender, their weight, their height, and that's how we can actually determine if a blood pressure is high or low. So having a strict cutoff like this probably isn't going to work very well. Similarly, there's huge size differences between, say, a 5-year-old and a 15-year-old, and 2 kilograms is going to matter way more to a 5-year-old than it might to a 15-year-old, even though 2 kilograms in general is a good amount for not intentional. But so, rather than having a strict cutoff like they did in the PVAS, or like here in the PVAS, it's actually based on a percentage of body weight. And so there's some things in here that I think are better, and there are some things in here that I don't think are as good and may struggle. And so that's kind of where we're at as far as evaluating disease activity. What else is interesting is none of these scores actually take into account imaging. Which is, I think part of it is because imaging can be a little subjective. But it's interesting, considering that imaging is a huge part of how we assess disease activity otherwise. We do images and we say, this looks like it's active and this looks like it's not. The other thing about ITAS, and that's cut off here, is it actually takes into account those inflammatory markers, the ESR and CRP, where the PVAS doesn't. And so another big challenge in kids is that we really don't have a huge amount of information on treatment and outcomes. We treat it the same as adults. That tiny little graphic that I showed earlier, that's really what we do in kids. We don't deviate too much from that. We certainly try and avoid cyclophosphamide as well. I think we work a little bit harder in kids to avoid those, although, well, that's maybe not actually true. But we're really just extrapolating from adult studies. We don't have a lot of studies really at all in kids that says this works better than that, et cetera, et cetera. Generally, and we also, again, we can say generally and based on the studies that are available, the kids do okay. Um, and respond to treatment and are able to do the things that they want to do. But we don't have a lot of data that shows more of those specifics. One thing that can also be a little bit tough when we don't have the studies is that insurance can be a challenge to get some of those more expensive biologic medications because they'll say it's not FDA approved and they'll say show us the data and then we don't have it. There are a number of prior studies on childhood Takayasu. This is from a paper back in 2022 where they made this really gigantic table that I had to cut into pieces as evidenced by my poor photoshopping right here. But there's a couple of interesting things about this. If you look at the size of these studies, there's three that are large, and I'm in large really in the context of childhood Takayasu. There's one that's 71, one that's 101, and one that's 19. You can see that all of the other ones, there's like 14, 17, 21, 40, 11, they're all these tiny little studies because of how rare the disease is. These larger ones are good, but they have their limitations, especially as we try to apply them today. They all occur either in one single hospital or one country, which may limit how we can interpret it from a worldwide perspective. And the to get the dates that they have, or to get the numbers they have rather, they have to have a really, really wide range of dates. I think the Chinese study went back 15 years, and it was like 2000 to 2000. No, it's like 1995 to 2010 or something. I can't remember off the top of my head, but it's a very wide range. But treatments have changed pretty substantially since, again, I keep mentioning biologics, since the advent of biologics. Those have come into much more play in the last 10, 15 years, probably more on the 10 side for Takayasu. So, as this table shows, we don't have a lot of data on it. We don't have a lot of data on Takayasu as far as treatments that are available now. And we just don't have a lot of patients in different places. So what are we doing about that? Well, I present the International Collaboration on Childhood-Onset Takayasu Arteritis. This was the fancy name that we came up with because we could just highlight it to ICTAC. But we'll probably need a better name once we get a little bit farther. So what is it? So it's a collaboration between CARRA, which is the Childhood Arthritis and Rheumatology Research Alliance. That's the mostly North American research group for pediatric rheumatology, and PRESS, which is the Pediatric Rheumatology group in Europe, between their Vasculitis Working Party. And we're collecting information on patients diagnosed with Takayasu before the age of 18, so our definition of childhood onset, but who were diagnosed in 2018 or more recently. And that's to try and get a little bit, that's to say, okay, we really want to see what some of those biologics do, see what different treatment protocols that we're more using nowadays are going to actually show us. And our goal, we want to get at least 100 patients from across the world. And what's really cool is that we haven't gotten data because I'll tell you, the rheumatologists that are contributing to this are wonderful. It is a absolute slog to get data from other places, and they have to go to their ethics board and get approval there, and then they have to talk to the lawyers and make sure it's okay for them to send the data to us, even though none of it's identified or anything like that. It's all completely anonymous. And it takes a long time, and then they submit like one patient because that's all they have. But what's really cool, again, is we've had, the process has been started for all of these places. We've literally hit, we haven't hit Africa, and we haven't hit Australia. And I don't think there's anybody on Antarctica. But otherwise, we've hit the other continents. And the other cool thing about that is actually the press side, so the European side, they are collecting their own data because of different regulatory things. So they probably have a huge number more stars on the Europe side because we're then just going to combine everything at the end. So we really have started a truly international cohort of this very, very rare disease, which is really exciting. And so what are our goals? One thing, as I mentioned a couple times, is we just want to describe how this disease presents, and from a really diverse cohort, from really diverse and relatively recent patients. We want to see how it presents, we want to see what their treatments are, and we want to see how they do. We also want to compare the activity scores. What is the best way to assess disease activity in these patients? Because I don't think we really have a good answer. And so what we're specifically doing it's a REDCap database, which is basically it's a secure cloud-based database that Vanderbilt came out with a long time, but they let everybody have it basically for free, which is pretty awesome. But it's a REDCap database where people put in, the other rheumatologists put in surveys, and it's specifically designed so we can calculate the different disease activity scores and then compare them. And the other thing that's kind of on my list too is, do we need to make a new one? Do we need to make a childhood Takayasu specific activity score, which I think probably would work well, but that's down the road. But the last goal that we really have is to create a global community. This, said it many times, it's a rare disease. There's not a lot of information on it, and the information is a little bit compartmentalized. And so we can, with this project, connect pediatric rheumatologists who are treating this disease, who have an interest in this disease across the world. And, we have our immediate goals, we have our immediate things that we want to look at, but establishing this community really would then allow us to say, hey, we can do more with it. Do we want to look at the genetics of it? And do we want to make sure we collect from a diverse amount of, people, so the genetics are actually diverse? Do we want to eventually start collecting patient-reported outcomes, which I think are really important, but really hard to compare when you have like one or two patients at a single center. So it's really exciting for kind of the future of what we can do with this. And just a shout out, this is my team. I'm not pictured here because you can see me already in a different picture. But from the CARRA side, James is our amazing, amazing fellow who has been an incredible leader in this group. He's up in Wisconsin. David and Kimberly are both up in Canada at the University of British Columbia. They run the International Pediatric Vasculitis Initiative, so PEDVAS, which has been collecting data on childhood vasculitis for decades. Vidya is at Nationwide Children's. She was actually one of my mentors when I was in fellowship. And Linda is over at Chicago, who's been also just amazing for us. Then on the press side, we have Mario and Maria, both in Croatia. And Maria is actually the head of the Vasculitis Working Party for press. And then we also have Musaref and Seza, who are both in Ankara, Turkey. And Seza has been, she does amazing, amazing work in a lot of autoimmune and vasculitis. So it's a really, really cool group that we have together. And I'm really excited for what we're going to be able to do with this study. And so if you're interested, I haven't had a chance to look back in the chat yet, but if you're interested in participating or know someone who is, please speak to your primary rheumatologist. And by the way, I almost forgot, back on this page, we do have some families that come to all our meetings and are like hugely involved. I wanted to give them a shout out before I forgot, but since their like pictures and information isn't necessarily publicly available, I didn't want to actually put them on the slide. But yeah, so if you are interested in participating, know someone who is, please speak to your primary rheumatologist. They can email me at the email right there. If you have questions or concerns, or what have you, or clarifications, any of that, and you don't get a question answered here, you can also feel free to email me. I'm happy to chat. Thank you guys so much for listening and for dealing with my power outage.
Well, thank you so much, Dr. Gagné. You can stop your share now. There we go. And I just want to remind everybody that if you have questions after listening to Dr. Gagné, you can put them in the Q&A box, and then we'll do our best to get to your questions and answer them. Just a reminder, he can't answer any specific questions medically about you or your child, but in general questions about Takayasu's arteritis or childhood onset. So I have a couple of questions that were pre-submitted, and we'll start with those while we give people time to think about their questions. Actually, you did answer most of the questions that we were looking for, so that's great because we know the answers from your presentation. But one of the ones that I'm not sure we've gotten a clear answer on is how's the response to treatment monitored in childhood onset patients with Takayasu?
Yeah, I think that's a fantastic question, and it really highlights one of the things we're trying to look at, right? We don't have great ways to monitor it. We monitor most of the time, so when you're checking in with your rheumatologist, we're checking labs, and we're really looking for signs of inflammation, assuming that we don't have another reason for it. Um, that those become abnormal, it makes us think, okay, are we missing some activity? We look for a lot of the same stuff that may be presented. So are you starting to get worsening headaches if that was one of your symptoms? Um, are you having leg pain again when you walk? Are you having the belly pain again? Thinking
Mm.
about how somebody presented really is usually it's how you're going to present again. It's not perfect like that, but that's certainly stuff we think about. And then, in the clinic visit, we're checking pulses. We're checking if you ever have your rheumatologist putting a stethoscope on your neck. We're looking for what's called bruits, which is just a sound that happens in the arteries in your neck if you have blockages and stuff there. And then usually most everybody is checking imaging at some sort of interval. Um, it depends on where you are in treatment. It depends on what was abnormal before. But usually I see people checking imaging roughly every 6 to 12 months, and looking, and again, just really looking for changes. Because one of the big challenges we might see is somebody has signs of inflammation that's mild, and we check again in 6 months and it's still there, but everything else is better. How much do we count that? It's hard to say. And so it's that entire picture that we're looking at that we're how we monitor response to treatment.
Okay, thanks. I was just going to say, based on what you were just talking about, many patients living with various forms of vasculitis, there's lab work involved. Is that something that's done with childhood onset talk?
Yeah, but it's not specifics. I guess it really depends on what your treatment is, because you need to do lab work to monitor for just some of the drugs that you're on. So
Mhm.
methotrexate, I'm looking at liver and kidney markers every 3 to 4 months or something like that. So there's always lab work for that. For Takayasu disease itself, we don't really have much. We'll probably look at blood counts because sometimes when there's inflammation, those change. But most of what we can really see change is those ESR, the CRP, the markers of inflammation. There's no antibodies we can track. There's no biomarkers. There's no blood markers that are specific to Takayasu. It's one of the really big challenges, and that I know a lot of smart people are working on too.
Okay, great. We are getting a couple of questions in the Q&A box. One of them is, has there been an increase in diagnosis in children in recent years?
I don't know the answer to that. I haven't specifically seen it myself. There's been some concerns about some of our other like rheumatologic diseases, especially post-COVID, that people are trying to look at a little bit. I haven't seen any significant changes in the incidence of Takayasu, but it's hard to say because it's so rare. So, if we have a slight change in the amount of people that we're seeing with it, does that mean that it's really becoming more common, or does it just mean that it only takes a small change to make a big difference when you have a rare disease? So I'm not sure. I think that's something that, we can also potentially try and see with this is like we can get some estimates with this project and say, oh, wow, is this more common than some of these old ones, or is it about the same?
Interesting. Um, there, can you tell us what you think the long-term implications of childhood onset Takayasu's are? Are there any concerns regarding growth and development? And kind of as a part of that question, a question came in, can the children or young teens, can they live a normal childhood with Takayasu?
So you definitely, yeah. So I think yes, you certainly can. A lot of it is really dependent on a couple things. One, the amount of time that there's been inflammation. delays in diagnosis can lead to kind of some worse things, which is again it's tough in this because it's hard to diagnose. And then there's also the what has been involved. So where in the body, where in your arteries, there was inflammation, how long it was there, and how long it took to become quiet. Um, there's absolutely no guarantee of bad things, and I see, just like referencing again, like I mentioned the couple kids at my center, they like forget that they have the disease. They're like they forget they have it until they come in for their monthly infusion. And like that's certainly the goal. Down the road, it really varies. There's some people that have inflammation in the vessels that is so severe that you need vascular surgery. But that's not a guarantee. That's really just it's a very, very, very wide amount of different presentations. And then what can also happen, because I think I saw this in one of the Q&As, is that you can, so if the inflammation is in the vessels for enough time, and this is really kind of variable depending on the person, what can happen is that is you can get fibrosis and kind of a loss of the normal architecture of the blood vessel wall. And so it can become stenotic, so it can narrow, it can, the wall itself can become weak and you can have aneurysms. And so these are things that don't necessarily have to be represented in active disease, but it can be from prior inflammation that caused damage within the blood vessel wall. Those are things that can have longer term ramifications. Those are things that can need surgery or have other sort of like cardiovascular issues. I think, again, it's one of those things where I wouldn't say everybody has that issue. And even if you do have some damage, there's no guarantee that it's going to cause problems. But, it's one of the things that I would also talk with your rheumatologist about is like, hey, what do my blood vessels look like?
Yeah.
Right? And where are we? What do we need to do down the road? I think for me, usually when I have a new patient with something like this, my number one goal is always to get them into a remission, get them into a good spot. But after that point, or even during that point, I think it's very reasonable to talk about 5 years, 10 years down the road. And this is a disease that has to be a little personalized.
Okay, and another question, I'm not sure the foundation of this, but do you collaborate with Dr. Peter Grayson and Dr. Caitlin Quinn at NIH?
I do not personally. Dr. Grayson does a lot more with adult disease. I don't know. I don't know Dr. Quinn. That name sounds familiar. Dr. Grayson is very, very big in the adult vasculitis world. And he was actually, I want to say, the first author on the classification criteria
Right.
paper from the ACR. But I haven't. He works with some of my colleagues on some of the things, but I haven't seen him do too many things in the pediatric world.
And I would say to the viewer that asked that, we have Vasculitis Foundation webinars with Dr. Grayson and with Dr. Quinn. So any information you were looking for about them is out there you can find that on the Vasculitis Foundation website. I was going to ask you, since this is childhood onset Takayasu that we're talking about, and you had said that means getting diagnosed before age 18, is that correct?
Mm-hmm.
Does it change the treatment that you all give the patients when they age beyond 18? Are they then, it was childhood onset, but does their diagnosis change? Does their treatment change? Anything as they age into adulthood?
Not really. The only like the only situation I would say in that regard would really be um, if there's been insurance issues, to be honest. When we run into problems where there's medications that are approved for adults, once they become adults, they can become easier to get. But otherwise, we really model our treatment of the childhood onset kids based on the adult treatment guidelines, and so there shouldn't be too much of a change otherwise.
Okay, I'm not seeing any other questions. There were some similar, but I think we kind of got them with those answers. Do you have anything that you would like to add? Just in the kind of questions that you've been getting, anything you think maybe we haven't thought of?
I think Lori actually put a chat or a question in the regular chat
Oh, right.
instead of the Q&A, which is fine because it's confusing to me too. Um, so probably is the answer to your question. So she said if a child is diagnosed very young, do they tend to have more issues as an adult with the disease compared to adult onset, or worse symptoms and outcomes than adult onset? So this is something that I don't think we have a huge ability to answer from a like research perspective. We just don't have the numbers of patients to be able to stratify them in an easy way from an age perspective. I would say from my experience, it's still going to be dependent on the extent of the disease and how long it was present and how long it took to get under control. Probably more so than age. But younger age, younger age probably is, I would say, a negative risk factor. Um, but I don't think that's the primary one. I really think, it's more so in terms of like what has happened and how quickly were we able to respond to it.
I think the questions and answers have been great today. I mean, I appreciate the time that you've given us. I thought there were a lot of good questions from, it sounds like some of the parents, but we appreciate the time that you gave us today, Dr. Gagné. I know that time is valuable for everybody, but especially for those of you doctors that are in research. And I just wanted to say thank you for that. I also, just in wrap up here, wanted to cover just a couple of things. We have information that we'd like to communicate about the VPPRN. Just to take a minute before we finish, we talk about research today. And if you ever want to know how you can have an impact on important vasculitis research, the answer is you should join the Vasculitis Patient-Powered Research Network. And I'm a patient champion for the VPPRN. So all I can do is encourage you to go to the vpprn.org website and look. They have biannual forms they will ask you to complete. I tell you, the forms take maybe 10 minutes twice a year. It's not hard and it's super helpful. I know that some of you are parents watching today. You can complete forms on behalf of your child. If you have questions, you can reach out to the vpprn.org. The staff through their website, they're very responsive. And it's a global patient registry. Patient data, that means your patient data, drives the research in vasculitis, and providing researchers with information about you and your experience is key for advancing the knowledge of vasculitis. And that's just like something that we think is super important. So we wanted to tell you about that today. Also, we'd like to thank the Vasculitis Foundation for hosting these medical webinars, and our sponsors, Amgen, AstraZeneca, and Novartis. And of course, Dr. Gagné, thank you for your support and your answers and your presentation today. It was awesome.
Thank you so much for having me. Thank you for all the people that were listening and are the great questions. I really appreciate it. And I hope to be back soon.
All right. Thank you, everyone.
Take care.